Good day everyone. My name is Dr. Talha Meeran. I am the heart failure and transplant cardiologist at Fortis Hospital, Mumbai. Today we have with us Dr. Santosh Dora, who is a cardiac electrophysiologist, also based in Mumbai at Asian Heart Hospital. We also have Dr. Karthik Vasudevan, who is a heart failure and transplant cardiologist at Bangalore in Columbia Hospital. The topic we have today is that we are going to discuss today is post-transplant surveillance, imaging, biopsy, or both. So we're going to get started right away. So we have several modalities available for post-transplant surveillance, starting with endomyocardial biopsies, cardiac MRI, 2D echoes with strain and speckle tracking, gene expression profiling, and cell-free DNA. Dr. Dora, what is the need to develop these alternatives to endomyocardial biopsy if biopsy is really considered the gold standard for detecting rejection?
Yeah. So biopsy is still considered as the gold standard to detect the rejection. However, there are a lot of other alternatives have come, but the reason why biopsy is not a very feasible option for most of our patients, there are many. I will just highlight few of them. Coming from the very practical point of view, one is the cost. Especially in our set of patient, cost is a major factor, and a single biopsy costs around 50,000. The hospital cost will be another 20 to 30,000, 80,000 per biopsy. If 1 year you do 10 biopsies, it costs around 8 lakhs, 9 lakhs. It is almost half of the transplant cost. So it is a huge cost burden for the patient. Second, the morbidity associated with the biopsy. Of course, in fact, biopsy was being done earlier days when there was endomyocardial biopsy, and also a lot of biopsies were done. Then it came down. Now with the transplant options, there are a lot of places, not a lot of centers, so the biopsies are going on. People are doing very safely, but still it is an invasive procedure, and any invasive procedure is associated with its own inherent risks, risk of bleeding, risk of perforation, tamponade, risk of tricuspid valve apparatus injury leading to moderate to severe tricuspid regurgitation. And in most of the places, they have shown that this moderate to severe tricuspid regurgitation, the incidence is very high. It is not
quite common. Yes.
It is very common. In some of the studies, it is almost a 50 to 60%. And average in one of the studies showed that a patient might require a tricuspid valve replacement in 7 years' time. So that is a big morbidity. And what about the children and childbearing ladies? You cannot subject them 10
radiation
sinus in a year. There is a huge problems in their subsequent years, chance of cancer, chance of all those things also we should take into account. So it is not feasible. Very small children also, it is not a feasible option, biopsy. So we will have to think about other things. The another thing which is a very pertinent thing about the biopsy is sampling errors. Now patient might be having rejection, but is it 100% time it will catch those tissues which are involved? This is a heterogeneous process. It is not a homogeneous process. Rejection is sometimes some myocardium is involved, some myocardium is not involved. And if it happens to catch the tissue from the myocardium which is not involved, then you will end up with a negative result, which is false negative. The patient is actually suffering from rejection, but we brand it as negative. So that is another issue. In the other way, if you detect the rejection, 50% of time you detect grade 1 rejection. What do you do with that? Nothing. You just continue the same medicines that you are going on giving. There may be some times you detect the grade 2 and grade 3. And grade 2 also, if you give to 3 pathologists, one will say grade 2, one will say grade 1. So there is a inter-observer variability. So finally, there is a lot of confusion regarding, you are doing a invasive procedure, trying to get some meaningful result, but the number of meaningful results are very minimal, and there also there is some confusion whether to treat or not to treat. So, basically the idea is to cut down the unnecessary invasive procedures. So, from that point of view, we need to have different modalities.
So, clearly there is a need and requirement, especially in our Indian setting, to develop alternatives. So, my question to you, Dr. Karthik, is what is the biopsy schedule in your institution? I know at each institution the biopsy schedule can differ, and in most of the places in India, the frequency with which we do the biopsies are not as much as those cited and recommended in the Western literature. Dr. Karthik.
Yeah, I mean, it's a very pertinent question because it's highly institutional oriented protocol. Most of the institutes in the West they do about 10 to 12, and we were discussing, you were telling in Pittsburgh they're doing around 14 biopsies. So
in the first year.
In the first year, yeah. And as Dr. Dora has also listed all the inherent problems in the biopsies. So, and also in India, the cost considerations and all, which he also discussed. So, most of the institutes in India, I think 4 to 5 biopsies is more practical.
In the first year?
In the first year.
Okay.
After that, it will be an yearly basis biopsy, and also it also sometimes, you know, it's an event driven biopsy. Suppose you suspect a rejection clinically or echocardiographically, you pick it up, then you just go and do it. So, just to confirm the grade and plan your treatment.
Okay, fair enough.
Yeah.
Dr. Dora, my next question is for you. Can you please summarize the medical literature for or against relying on cardiac imaging modalities such as cardiac MRI and more recently 2D echo with the speckle tracking for post-transplant surveillance? Is there any indication one way or the other in the current literature?
Yeah. So, we are all cardiologists well versed with the echocardiogram, which is a great tool available to us, and it is of great help also. I think echo should be the first line imaging modality for these patients. The children will benefit, ladies will benefit, normal adult will benefit. Of course, there are some few people who are very obese and the echo window is very poor, it may be difficult. Now, echo has its own problems, of course. We have conventional echo, we have some advanced echo system. So, nothing is less important. Conventional echo is also not less important. If we measure the dimensions properly, the diastolic velocity, systolic velocity, and the tissue Dopplers and all those things, and keep a baseline, and try to see what is happening in the subsequent visits to that baseline measurements. That itself is a great tool. If you think that there are deviations, and there are deviations in multiple parameters, then you know something is wrong. And these are the patients which will be having a high threshold for subsequent cardiac biopsy. Now, if everything is absolutely perfect, then you know that this is negative. This is, you do biopsy, it will be coming as negative. Now, there might be possible that especially in the early stage of rejection, like grade 1, the overall tissue, the echo picture might be looking normal. So, in those cases, the advanced modalities might come into the play, like strain imaging, and so it has the ability to capture even when the subclinical events, the patient may not be having really the LV function may be still normal, but still if you have in a global longitudinal strain, if you can demonstrate that there are multiple segments are lacking the strain, the normal strain pattern, then you know there is something wrong. So, then you can pick. So, the ability of the echo there is a great ability of the echo to predict that majority of people are probably normal. You do not have to unnecessarily do the invasive test. When you see that there are some people who are having some deviations from the normal parameters, then you do the biopsy. Again, the problem is when you actually acquire the baseline value, that is a big debate, whether it can be taken at 15 days of transplant, or can be taken at 1 month of transplant, or it should be 6 months of transplant. Majority of the studies they say that it is 6 months of transplant. But 6 months of transplant is too late for us. The maximum rejection happens within that, 3 to 6 months. After that, the rejections are very rare, extremely rare, very rare. So, that is where we have to find out more, we have to look into more details into the echo, how it will help. In 2010, one group in Iran, they had thought about the echo score to detect early rejection. They have taken they have taken multiple parameters. Out of that, they found that posterior wall thickness, LV mass index, the lateral wall strain, and the time to strain, time to peak strain. So, these are the 4 parameters they found out, and they calculated and made a score. When the score is more than 0, probably they are at risk. When the score is less than 0, almost 100% of patients are negative for biopsy. So, similar to that, something should come up which is very solid enough to especially rule out the negative, to find out the negative cases. So, then we just concentrate on a few positive cases where we send them for the biopsy. And there is a this European Society of Advanced Cardiovascular Imaging, they have given a very big summary that came in 2015. They have enlisted all these things. Of course, they did not pinpoint which particular things will be beneficial, but again they have given more stress to the strain imaging compared to the others. Now, as far as the MRI is concerned, again I will consider it as a second line therapy, second line investigation modality, because of it may not be available everywhere. Again, the software to detect may not be available in all the machines. Like the most important softwares are these T1, T2 mapping and the extracellular volume fractions. So, in fact, in my hospital the MRI does not have that. So, that is the thing. Again, there is a good chance with these modalities we might be able to rule out the true negative cases and pick up some few positive cases which we may subject for the endomyocardial biopsy. But again, cost is also a factor for MRI compared to the echo. Many echoes, poor patients will do it free even, but MRI you can't do it free, of course. And how many MRIs you will keep doing? So, these are the issues with MRI.
Okay. So, looks like we still have to learn quite a lot on the imaging modalities that are being utilized. We do have an idea with trying to form composite scores on 2D echoes, not so much for cardiac MRI yet, and cardiac MRI perhaps still there is an issue in our country about availability and costing. So, fair enough. So, moving on, maybe other than imaging, is there something else? Are there simple blood tests? I know that at some point we also looked at serum biomarkers such as high sensitivity troponins and proBNPs to help us. Now, do you think there is a strong role of these modalities in post-transplant population?
In post-transplant, I don't think so. Especially BNP and troponin have been tried earlier, but they are not found to be that useful in pinpointing the, you can't completely go by it. Like you need, even if they are positive, then what next? Then you need to go and.
Is there a particular cutoff for, say, a troponin which increases the positive predictive value of that in for rejection?
I'm not sure about all that particular.
I had come across one study where they have highlighted the role of SERCA, sarcoplasmic endoplasmic reticulum 2A. What they are saying is this can play probably a great role in where this amount in the bloodstream, it decreases when there is a heart failure. So, in the patients with rejection, it decreases. Now, and the decrease is a graded decrease, that is what they are highlighting. There is no rejection with normal population, what is the level? A transplant patient with no rejection, what is the level? The transplant patient with grade 1 rejection, what is the level? Grade 2 rejection, what is the grade 3 what is the rejection? So, they found a linear correlation, like the grade 3 is the minimum, grade 2 is little more. So, that what they are trying to say is it not only rules out the patients with no rejection, but it also very pinpoint in telling at what stage he will be. So that in a grade 1 you may not have to send for biopsy, even if you know that it is grade 1. In grade 2 and grade 3 you send for biopsy. So this is maybe a preliminary study. I think further studies will help in.
So moving on, gene expression profiling, specifically the AlloMap test, has been around in US and Europe for quite a few years. Still not available in India. The Cargo 1 and Cargo 2 studies were really positive, and that really hit them off in the US and Europe market. Dr. Karthik, you have had some experience at US centers. Can you briefly tell us how it's being clinically used at those centers?
Yeah, AlloMap at present is the only very promising modality we have got to do the surveillance. It was way back in 2005 when the initial clinical trials were started, the Cargo which you mentioned. I think Cargo 2 came, and after that in 2010 I think the US also, it was included in the guidelines, ISHLT guidelines also. AlloMap is a gene expression profiling wherein they look at 20 genes, out of which about 11 of them are transplant rejection related, and the rest 11 of them, and 9 of them are control genes. And after they do the test, they give a particular score from 0 to 40. It's a single digit score is given, and anything more than 34 it predicts a rejection. And this is positive as early as can be used as early as 2 months. And of course they've got a differential score from 2 months to 6 months. You take a cutoff of 30, and after 6 months you take a cutoff of 34. And one more thing is it can detect only ACRs. It cannot detect AMR. So that is the drawback. And other thing is, if there is also an late rejection and then also a high risk group, you cannot use this. And if this is at present approved for a low risk patient profile, wherein you need to do a surveillance, you can use it. And this is quite often used in US, and after 6 months, in my center where I work, they started using after 6 months. They never used it early. But now there are studies which have shown that it can be used as early as 2 months. It's an excellent tool. But coming to the Indian scenario, it is the cost and availability. And it's a cost roughly about, if I'm not wrong, it's around $3,000 to $4,000 per test, which may not be practical in our Indian scenario. So, and also at present it's not even available. Once it is available, the cost come down. I think it's an excellent tool we can definitely use, and thereby minimize the number of biopsies.
Correct. And I think if we use it more and more, then we can also get the cost of the
down,
test down. Cell-free DNA is the new kid on the block.
Yeah.
Your thoughts?
Yeah, cell-free DNA, the concept is like it's a graft-derived DNA. Immediately after the transplant, there's some amount of injury to the graft. So it peaks, it doesn't go more than 5 times. Maximum by the end of 1 week, it comes down to almost 0.5%. And after that, it stays at that. I mean, in case there's a graft injury, then again it goes about 5 times more. And when you do a test to detect these levels, then that may be a very good marker for diagnosing rejection. Now the cutoff, they are using it as 0.2%. It's given as a percentage. It's called...
It's a donor fraction.
Donor fraction of the cell-free DNA. So it's got a very good sensitivity and specificity, and it can be used again, whether it definitely is ACR, but AMR again it's a question. Now when you order AlloMap, you're also getting AlloSure. The same company is doing the...
That's free of cost,
it's now at present free of cost. We don't know afterwards how much it's going to cost. And most of the doctors whom I have spoken to, they got the data now, they don't know what to do with it. Whether we can rely on it, or we can still have to wait for the some more studies to come. And there are studies which have combined these two, and they have tried whether these two can be complementary to diagnose a rejection. And the sensitivity has been around 88%, and the negative predictive value is very good. It's somewhere close to 98, but the positive predictive value is very dismal, around 8 to 10%. So you can rule out, but not rule in.
So similar to the allomap,
Similar to
cell-free DNA
allomap,
also.
yeah.
So fair enough. So I think that's it for questions. I would just take a minute to summarize. So we talked about all the imaging modalities, including echo as well as cardiac MRI. Between the two, because of ease of availability and cost, as Dr. Dora was explaining, echo seems to be the more viable and go-to option now. Again, none of these individual imaging modalities can or should be used on its own. It should be combined with our clinical suspicion for rejection, and we may eventually need to do a biopsy to confirm our clinical suspicion. Again, the diagnosis of rejection is made on biopsy. It tells us whether this is cellular or antibody mediated, but we can take help from all these additional testing to help us guide which ones should get more frequent biopsies. Then we also talked about the more promising gene expression profiling and cell-free DNA, both of which modalities are not available in India, but when they do get available, they seem like very promising options to help us decide. Perhaps in patients who have very, very low risk of rejection based on gene expression profiling and cell-free DNA, we can actually save money by avoiding biopsies. With that, we would like to conclude this session.